Our second speaker is from Italy. He is Professor Paolo Manzoni, and he will join virtually. And he will talk on the management of neonatal infections beyond antibiotics. Professor Manzoni is a board of director for Italian Society of Neonatology. And he is a board of editor for the Italian Society of Neonatal Infectious Disease and an associate member of American Society for Pediatric Research and Italian Society of Neonatology. He is also an external consultant for pediatrics and neonatology for the Italian Drug Agency and for the Pediatric Committee at European Medicine Agency. So without losing further time, it's over to you, Professor Paolo Manzoni.
Hello, everyone. It's Paolo Manzoni here, and my lecture is focusing on the management of neonatal infections beyond antibiotics. I am a neonatologist and a pediatrician, and I'm the head of an academic department of maternal infant medicine in the University Hospital of Biella and Torino in Italy. This is the outline of my talk. We'll have some refreshing information about the burden of the disease, about the diagnosis, and about the prevention, and then we'll focus on the management with a main interest in stewardship in use of antibiotics and in management of the central venous sepsis. As for epidemiology and morbidity, we all know that we are dealing with infections that may occur, especially in very low birth weight infants, between birth and the first weeks of life. As such, the main bulk of infections are called late onset sepsis, meaning that they can arise after at least 3 days of life and can be detected till 60 days of life. In this portion of infections, the main pathogens are E. coli, staph, and Candida species. The problem with infections in neonatal period is not only about mortality, but also about long-term neurodevelopmental impairments with the negative outcomes that are strictly related to the occurrence of a bloodstream infection in preterm neonates. As for morbidity, we have two pieces of data that I will show you and comment here. The first one comes from the Canadian Neonatal Network. It's a very comprehensive one with almost 50,000 very low birth weight infants recruited and whose outcomes were reported in this study. You see here that most very low birth weight infants in this database have received 4 to 7 days of antibiotics for the suspicion of an infection, even though not later confirmed. As such, more than 1/3 of low-risk infants were actually exposed to long courses of antibiotics. And what's very intriguing and at the same time very concerning, there are negative outcomes associated with use of antibiotics and exposure of antibiotics. The composite outcome that you can see here being prevalent with a 40–50% more odds in the exposed neonates are all negative outcomes related to prematurity, namely IBH, chronic lung disease, ROP, and necrotizing enterocolitis. The point is clearly what's coming first. If infections determine the need for antibiotics and hints the risk for negative outcomes, or if it's true the way around, that is, when we are exposed to antibiotics early in life, this increases the risk for these outcomes. More detailed data can be taken by the reports of the neonatal infectious network of Spain. In Spain, a group of hospitals, more than 80 hospitals, is gathering data about infections and has been doing so since the late 90s. The incidence taking into account a year like 2018 was around 20% in very low birth infants, with an increased prevalence for repeated episodes. There's a certain trend towards decrease in incidence of late onset sepsis along the years. In the last 10-15 years, 25% less episodes have been reported, but however, this decrease has been true only for the proportion of very low birth weight infants with the highest weights. In other words, no significant difference in incidence of late onset sepsis has been occurring in extremely low birth weight infants, that is, those less than 1,000 grams. One major driver of the reduction of late onset sepsis along the years has been the reduction of Candida infections. And this has been occurring thanks to the adoption of routine fluconazole prophylaxis in many neonatal centers. Also, exposure to H2 blockers or exposure to probiotics has been changing over the years, and this has been another factor accounting for a somewhat slight but certain decrease in infections in the very low birth weight infants, neonates. Conditions associated to sepsis in those neonates in Spain were the association with a central venous catheter infection in 50% of cases, the association with neck in 80%, as well as for meningitis in 8% of neonates, and the occurrence of urinary tract infection in a very small proportion of neonates, more than 2%. As for isolates, gram-positives accounted for 2/3 of the isolates, whereas gram-negatives accounted for 1/3, with a minor role for Candida species, 6.4%. Among gram-positive, staph epidermidis plays the major role, and among gram-negatives, Klebsiella, Enterobacter, and Nicoli share more or less the same figures. The trends in pathogen etiology along the last 12 years certify that there has been a statistically significant decrease for fungi, but not for gram-negatives or for gram-positive, as I was telling you. And last but not least, mortality related to late onset sepsis is mainly attributable to gram-negatives, very high, whereas for gram-positives it remains low. Please remember that for Candida species, mortality remains extremely high, even though the incidence of those episodes are on the low. Let's speak a little bit about diagnosis, because when we think about management of infections, we need to focus on diagnosis in order to appropriately identify the patients who need management. In this view, the blood culture is still the gold standard for diagnosis, but in neonates, and especially in preterm neonates, this exam is hampered by several weaknesses. On one hand, the sensitivity of a good blood culture is high also for low bacteremia inoculums, but it's proportional to the volume of blood that has been drawn. Since the sensitivity is optimal with the volumes 2 to 3 mLs, it's clear that with preterm neonates, we often have the risk to collect much too low volumes of blood in order to have a positive result. Remember also that gram-negatives grow faster than gram-positives, and remember also that at 48 hours, the vast majority of blood cultures that become positives are already positive. Time to positivity is independent from several factors, with the major associated factor for time to positivity being the bacterial charge, the bacterial count of colonies that is present in the blood sample that has been drawn. In this view, it's always very advisable to draw the blood culture when phases of bacteremia are likely to be there, as an example, when fever peaks occur. But unfortunately, in preterm neonates, fever is often not present, and phases of bacteremia may be fleeting. Therefore, it's very difficult to be such timely to detect the peak of bacteremia. One important information comes from this historical study that tell us that 98% of blood cultures are actually positive after 48 hours when they are destined to become positives. In other words, if we call the micro lab and ask for the state of a blood culture 48 hours after having drawn the sample, if the laboratory is telling us that no pathogen is growing, we are pretty much confident that this blood culture will remain negative. And therefore, we may withdraw antibiotics provided that the neonatal conditions are in line with this. It's important also to remind that the biomarkers of sepsis are fleeting, have not overlapping peaks in value, and have a timeline of variation over time that is typical for each one of them and very different from one to another. The most important and the most used ones are usually C-reactive protein and procalcitonin. And as you see here, C-reactive protein takes at least 24 hours to increase when an infection occurs, whereas a procalcitonin takes 12 hours. Therefore, it's always very advisable to use in a combined way different markers, and not to rely on one single only biomarker if we are not sure enough about the timing of this marker. Another very point that comes after these considerations is that the role of laboratory markers may be therefore not that useful in the diagnosis of sepsis, but more useful in guiding and assessing the response to therapy, and therefore in guiding us to withdraw the therapy. Please remember that at the end of the day, the most reliable indicator of sepsis remains the presence of clinical signs with a very high sensitivity. If we are not confident about biomarkers, all studies tell us that clinical signs are usually the most reliable markers. And therefore, we need to know very well which are the clinical signs and symptoms. There are physiologic changes in sepsis that involve the neurologic system with lethargy, decreased activity, hypotonia, and seizures sometimes. That involve the gastrointestinal system with ileus, emesis, or gastric residuals, and up to the necrotizing enterocolitis feature, but also cardiovascular system is very heavily affected with hypotension, with variation in the heart rate characteristics. And these might be a useful tool, as we will see later on. Heart rate characteristics may actually help an informed diagnosis because when we have an histogram of the heart rates trend over time, we have a nice and smooth alternation between decelerations and accelerations in the heart rate. However, when an infection is there, this trend that is depicted by this histogram becomes abnormal in that many large deceleration and few or no acceleration are detectable. So the histogram has a tail caused by the large acceleration, and this can be visualized in our monitors. A so-called HRC index, a score from 0 to 4, has been calculated by a machine that uses an algorithm derived from the heart rate characteristics and their trends, and where this index is increasing from 0 to 2.5 or 3, this is usually associated with the time of septicemia, and this is true for all pathogens from all classes and organisms. In sepsis may affect heart rate characteristics because there are agents in the bacterial cell wall like LPS or LTA that can influence the heart rate characteristics, as well as other agents in the fungal cell wall. As a matter of fact, LPS, the major antigenic site in the cell wall of gram-negative rods, is able to decrease the heart rate values in mice in experimental models, and therefore these can be captured by this algorithm. A study, a randomized clinical study in humans, has been conducted some years ago with more than 3,000 very low birth weight infants in USA, randomized to heart rate characteristics monitoring or no monitoring, with primary outcome the survival after randomization free from disease, and as a secondary outcome, the in-hospital mortality. The results are very striking because in the control study, in the study group with the babies monitored continuously with the heart rate characteristic tool, there was a decrease in mortality by 25%, and this was highly significant, with one extra survivor every 48 very low birth weight or every 23 extremely low birth weight infants monitored. So this tool gives us the possibility to better capture babies in need to receive antibiotics and to be an add-on tool with respect to the biolaboratory markers or with respect to the clinical signs of detection. Another very nice and even easy way to identify infants where infection is occurring is the monitoring of the central peripheral temperature variations. This has been a study conducted in Spain with a nice assessment over time of the temperature measured in a central versus a peripheral site in these babies. Usually the difference between central and peripheral is not higher than 1 or 1.5 degrees. But it has been noted here that when infection was occurring, this gap was widening, was getting wider and up to 3 degrees. Detection of this widening gap was significantly associated with a very high sensitivity and very high negative predictive value to the occurrence of late onset sepsis, and this was independently associated. In 70% of cases, this alteration in the thermal gradient was the very first clinical sign of sepsis when even biolaboratory markers were still normal in their values. Therefore, the detection of a sustained increase in the central peripheral temperature difference is an early sign of evolving late onset sepsis, and as such is a tool that is simple and needs to be implemented in the daily neonatal care in our nurseries. But another way to manage, and a very important way to manage infections, is to prevent them. And we have a very important role here for fluconazole. This is our historical randomized clinical trial in the New England Journal of Medicine 15 years ago, showing a reduction by 75% of infections in the fluconazole prophylactic group compared with placebo. Please remember that human fresh milk is very much able to prevent sepsis with a 57% reduction in sepsis in those preterm neonates fed human milk. And the beneficial effects of human milk depend on intake volumes, in that the more we get and the more we get protected. As you see here, the threshold values enabling a preterm baby to get protected is at least 50 milliliters per kilogram per day of human fresh milk. Lactoferrin also is able to play a role. This is the last and most updated and recent meta-analysis showing out of 12 randomized clinical trials that lactoferrin is able to provide a 19% reduction in late onset sepsis in very low birth weight infants exposed to lactoferrin on a daily basis. Another important point in the management is to avoid the use of H2 blockers and gastric inhibitors, gastric acidity inhibitors. Every additional day of H2 blocker exposure confers an additional 3.7% odd to develop infections in preterm neonates. Therefore, this practice is absolutely to be avoided. It's also to avoid the routine use of prophylactic antibiotic to reduce morbidity and mortality in neonates with umbilical venous catheter, in neonates with umbilical artery catheter, and in neonates with the central venous catheter. In other words, there is no significant advantage in babies prophylaxized with antibiotics when they have such a venous access inserted. Therefore, it's absolutely not useful to use antibiotics to prevent infections in such a situation. And more generally, there is no evidence to support the use of any prophylactic use of antibiotics in the NICU. This is in accordance with the CDC policy statements. The CDC definitions for bloodstream infections point out very clearly that bloodstream infections and cultural catheter and catheter-associated bloodstream infection may originate from catheter, but need to be avoided with the use of bundles and hygiene measures, and not with the use of antibiotics. Sepsis are associated with the duration of CDC maintenance, and therefore there is a need for a correct management of central venous catheter. When we have a catheter remaining in place for longer than 10-14 days, the odds of infections increase abruptly and advocates for a change in the catheter. In this view, another very important tool is to promote education and skills in the management of catheter, because the incidence of catheter-associated infections is much higher in those units where a specific group attending neonates in need for a catheter venous access positioning are not formed. In other words, if we create in our nursery a group of nurses and doctors able, skilled, and expert in managing the catheter, we are likely obtaining a reduction in the incidence of those episodes. And therefore, this slide summarizes all the bundles related to the prevention of infections related to central venous catheter. We have to perform several actions that are summarized and outlined here. All of these actions need to be performed concomitantly if we want to reduce the burden of CDC-associated infections. Also, we have to implement the bundles of prescription and of discontinuation for the use of antibiotics. This Lancet study in 5 years ago was an observational one conducted in Dallas in the USA, in one of the largest NICUs in the USA. They simply adopted an intervention in a period of 9 months where empirical antibiotic therapy was set and planned to be discontinued after 48 hours in the electronic medical record, and as a second step, the duration of therapy for pneumonia and culture negative sepsis was limited by the system to 5 days. By simply implementing these two measures, there was a reduction by 27% of the use of antibiotics, with no difference in negative outcomes between the first and the second period. So these claims for reduced use of antibiotics, but concomitantly for an increased use of hygiene measures, and hygiene measures rely on hand washing. Hand washing is the ultimate tool to prevent infections, and this has been shown very clearly, not only by this very pictorial study, but also by all the studies that have compared periods where reinforced hygiene and surveillance and prevention measures were implemented with the previous period. You see here green bars intervention period, red bars pre-historical intervention period. There has been always a reduction in infections when we implement hygiene measures. The only problem is to keep sustained this reduction, is to keep present and ongoing this reduction, and not to relax in our hygiene measures. Stewardship in the use of antibiotics implies that we need to implement a list of key points for the appropriate antibiotic management of infections. So, first of all, let's remember that we need to consider any premature infant with microbiological or clinical evidence of infection as having disseminated disease, and therefore we need to perform all measures to screen out end organ involvements and to perform careful follow-up to capture late neurodevelopmental impairment as negative outcomes of the infections. We have the option to implement a targeted therapy, and this occurs very rarely, or to implement an empirical or preemptive treatment, and this last option is the most frequent one. Rules about the choice of antibiotics imply that a combination of agents against both gram-negative and gram-positive is recommended. We need to use a narrow-spectrum antibiotics by starting antibiotics with the most possible limited spectrum, and in order to target as much as we can, and to reserve meropenem and imipenem as an example to selected cases in order not to select carbapenem-resistant strains. Broad-spectrum antibiotics are associated with increased risk of systemic fungal infection, and the same occurs with repeated antibiotic exposures. Therapy adjustments need to be based on the microbiology findings. With this in mind, the most advised and used combination of antibiotic for empiric treatment is with ampicillin and aminoglycoside for early onset sepsis, and vancomycin plus an aminoglycoside for late onset, with teicoplanin or piperacillin tazobactam as a second line, and meropenem or micafungin only as third line. Duration of antibiotic treatment needs to be at least 2 weeks with confirmed bloodstream infections, but needs to be up to 4 weeks in meningitis, with at least 2-3 weeks after sterilization. In any case, recommended duration is at least 7-10 days after the first negative blood cultures. This is an editorial that we published in The Lancet 3 years ago with 4 main points that we suggest in order to reduce the unnecessary antibiotic exposure and to obtain the goal to have less negative effects associated with the possible enhanced exposure to antibiotics. The first point is to start empirical, but to discontinue antibiotics after 48 hours if sepsis is not confirmed. The second point is to try short duration of courses of antibiotics if sepsis is confirmed. The third point is to use antibiotics when needed, but to avoid unnecessary prophylactic exposure, as an example for central venous catheter positioning. And the fourth point is to reinforce prophylaxis in order to prevent infections by implementing bundles of care, bundles of CDC management, hygiene measures, and adoption of all prophylactic pharmacological and nutritional strategies that has been associated with reduction of infection, fluconazole, lactoferrin, probiotics, fresh human milk, etc. Thank you very much for your attention.